hopefully in your BLS classes and in your future, that is not the experience you get with CPR. So. All right, so we did our EKG review yesterday, and hopefully either it was something you already knew, there's nothing new you learned from it, or hopefully it kind of brought some memories back from earlier in the semester to help you understand how to read EKGs better and maybe feel a little more confident in reading those. But the whole point in this block is, one, recognizing an arrhythmia and why and what is going on with that arrhythmia, and then how to treat it, how to manage that arrhythmia so that our patient don't die on us if they were to develop this arrhythmia in front of us. So to kind of achieve that goal, we first have to understand, we have to talk about, why do arrhythmias develop in the first place? We've been hitting all along that the cardiac cycle is such a tightly regulated system. How can something abnormal develop in the first place? And that's what we're going to talk about in our lecture today. So how do we get this electrical conduction, generation, then conduction, that results in an effective and organized squeeze to pump blood out of the heart to the systemic arterial system and then back to the other side of the heart? How does this happen? How is this regulated, and how do we recognize what's going on when it's wrong? So the first thing we got to talk about is the pacemaker cells. So these are the cells in the conduction system that are designated to actually generate that action potential. They display a concept of automaticity, which is unique to the pacemaker cells, where they can generate that action potential and then propagate down that conduction pathway in order to organize and coordinate that squeeze. And the cells that we have that can generate these action potentials are, of course, your SA node, which is, of course, what we typically think of as the generator for the heart. But other cells in the conduction system can do this as well. So like the AV node can generate its own action potential if required. The bundle of His, the left and right bundle branches, they can generate their own. And the Purkinje fibers can do it as well. But we also learned that that automaticity is regulated at these different areas where there's a preset rate on which these action potentials are going to be generated in those different pacemaker cells. And the SA node has the fastest rate, which is why it tends to drive the cycle. Because what happens is, you get that SA node generating that action potential, it then propagates down to the AV node. By the time the AV node is ready to generate its own action potential, it's already depolarized because that action potential from the SA node has already arrived there and depolarized it. So you don't get another action potential generated to trigger kind of this discoordinated response. But if the SA node fails, either because it's under stress from ischemia or it's dead because of an infarct, the other pacemaker cells will pick up the slack and generate that action potential to at least give you that heart rate and that heartbeat to circulate the blood. Now that's in a normal heart, in a normal action potential generation. But what happens in the abnormal? This is where the arrhythmias are. Why do arrhythmias develop in the first place? And there's really two main kind of umbrellas that arrhythmias fall under. It's either there's something wrong with the formation of the action potential, or there's something wrong with the conduction of the action potential. So the action potential going from point A to point B, something in there interferes with that and alters that propagation. So what are some examples of these two abnormalities? So when we talk about altered automaticity, or the generation of these action potentials, you can have it where either the normal automaticity is affected, or you have an abnormal automaticity. So what are these things? So altered normal automaticity is like parasympathetic nervous system is slowing things down, and it could be slowing it down excessively. It could be that the sympathetic nervous system is speeding things up inappropriately. So this would be like an anxiety attack, causes your heart rate to kind of start beating fast, right? Starts pounding in your chest. It's because of that sympathetic overdrive that's going on, right? Now you can have escape rhythms, which is when the SA node for some reason doesn't generate the action potential when it should, so other pacemaker cells generate that action potential. That's called an escape rhythm. Now, an ectopic beat is when that action potential generation of, say, the AV node speeds up for some reason. So, say the sympathetic nervous system stimulates the AV node to generate action potentials faster than it normally should. So what ends up happening is now that faster AV node development of action potentials is going to be faster than what the SA node can do, and now you're going to have these ectopic beats or ectopic rhythms developing from other pacemaker cells and overriding the SA node. So that's the difference between an escape rhythm is SA node is slowed down so other cells pick up the slack, and then the ectopic is those other cells produce their action potentials faster than the SA node. Now the other thing is abnormal automaticity. So we said that pacemaker cells are the only ones that should generate those action potentials, right? But what happens if I have scar tissue that develops from an MI? What happens if I have some other pathologies going on, like deposition disease or something like that, where now, let's say myocardial cells that should not have the ability to generate action potentials now develop the ability to generate that action potential. All of those things that regulate that action potential generation, propagation, and conduction no longer have the same impacts on myocardial cells that they do on the conduction pathway, right? So now you can see if that ventricular myocardium develops the ability to generate its own action potential, it's not answering to anybody. It's just going to do whatever it wants. And then there's these triggered activities, which it's kind of confusing sometimes, but basically you have early after depolarizations, which is in the situation where you have an action potential that goes down, you get the depolarizing event, and then it starts to repolarize, but not all of the cells have repolarized. But because you have some cells that have repolarized, if another action potential were to generate, say like an AFib, it could trigger a depolarizing event to occur in just those cells that have repolarized. So is that going to lead to a coordinated response? And the answer is no, because if I only have 10% of my myocardial cells that have repolarized, I'm only going to have 10% actually ready to respond to that, that signal that came down. So now I'm only having a 10% response, not the 100% response that I want. The other triggered activity is these delayed after depolarizations, and these would be in situations like with hypercalcemia, where you have it where the cells have all repolarized, but you haven't really gotten the cell membranes back to normal yet. Like that phase 4 of the action potential hasn't carried out for the full duration, and then that action potential generates or is generated and triggers a response. But you can see, okay, I get the same kind of depolarizing event, but the rest of my cycle is not there because I didn't give the full time for phase 4 to occur. So those electrolytes are not, across the membrane, are not back to where they should be in order to respond normally and appropriately. So that's how altered impulse formation can trigger different arrhythmias. But let's look at the conduction side. So we said there's something wrong with going from point A to point B that's causing this arrhythmia to develop. And there's two main types of conduction issues that can be encountered. So we can have the conduction blocks, which would be, think of your right bundle branch blocks, left bundle branch blocks, where the wire is cut going from point A to point B, so it's got to find a roundabout way to get around that. And this can be something transient, so if you just have ischemia, you can get this, but it could be permanent. So if I have a ventricular septal infarct from a LAD occlusion, I can knock out my bundle branches, and now that's permanent damage, and now I have a permanent conduction problem. The second type is a unidirectional block and reentry. So it's kind of a complicated thing, but basically what happens in this setting, and we'll talk about some examples of this arrhythmia tomorrow, or sorry, on Monday when we come back from the holiday. But with unidirectional block and reentry, what happens is, as that action potential is coming down, it's going to encounter a fork in the road, right? And what's going to happen is that action potential is going to go down both sides or both limbs of that fork normally. And that propagation is going to go down until it encounters its own fork in the road. And then it's going to go both directions in that fork. But it also goes maybe towards each other. But what happens is you have depolarizing occurring along this way and depolarizing occurring along this way. So you're going to meet in the middle in this example, and then that propagation in that area is going to stop. Because it can't, going from right to left can't continue in the leftward direction because that cell has already been depolarized. It's not ready for another depolarizing event. It hasn't been given the opportunity to repolarize yet. And then the same goes from the left to right, where that rightward propagation is going to terminate because it's going to encounter depolarized cells that are not ready for repolarization. Now, something that may happen is, let's say we go back and that initial action potential hits that initial fork in the road, and it's going to go down the right side normally, but the left limb, let's say there's an area of an infarct where that conduction is killed, it's not going to necessarily propagate that signal. So what ends up happening is it's going to go down the other limb, and then that limb, because it's not going to encounter that area of depolarization, it's just going to continue to propagate down that other side. So you can see this is going to lead to a delayed kind of depolarization going down that left side, because now it has a greater distance to travel in order to depolarize everything on the left. But the third example of this unidirectional block and reentry is, let's say that you had an action potential generate, but because of some damage that's occurred in this area, it just takes a little longer to repolarize that area, so that area can then accept a depolarizing event. So what ends up happening is it's going to go down the right limb normally, encounter that fork in the road, it's going to go to the left, but because this tissue is not depolarized, it will then speed back and go back up. It's going to loop back up. But in that time that it took to go down the right limb and over to the left, this tissue is now ready to accept a depolarizing event. So then what happens is this will then depolarize, and it will continue to propagate this signal as long as the cells that it's going to have repolarized and are ready to accept that depolarizing event. And what can happen with this is you get this short circuit where now you had that one event now lead to this circular response. And it just continues to go without any regulation as long as that propagation time allows those cells to repolarize before that depolarization wave gets there again. So you can imagine, and we'll talk about in our next lecture, the situations that this occurs, but you can imagine what's going to happen to your heartbeat. You're going to be totally it's not going to be regulated, and it's not going to respond to normal physiologic response because this is occurring outside of the regulated areas of the conduction pathway. When we talk about bradyarrhythmias, some examples of things that cause a altered impulse formation are things like decreased automaticity. So your parasympathetic overdrive can cause sinus bradycardia. When we talk about altered impulse conduction arrhythmias, what we're talking about from a bradyarrhythmia standpoint is going to be your conduction blocks. So like first, second, and third degree AV blocks are all potentially bradyarrhythmias that we could see in our patients. When we talk about tachyarrhythmias, now we can get altered impulse formation by enhancing our sympathetic stimulation. So we're going to have that sinus tachycardia. We could drive the AV node to be the pacemaker cell. So you're going to see those AV junctional tachycardias. You can get ectopic things. You can get those triggered activities. But with altered impulse conduction, instead of the blocks like we see with bradyarrhythmias, you actually are going to see those reentry circuits, which would make sense why that would be a tachyarrhythmia, because that circuit's just going to continue to self-perpetuate that rhythm. When you encounter an arrhythmia, it really, to kind of help you assess what is going on, you've got to look at the P waves, and you need to answer some questions regarding those P waves to get a better understanding of what is going on in that patient and why they are experiencing this arrhythmia, which then can also lead to how do we manage this arrhythmia properly. So the first question you got to ask is, do you see any P waves? If it is a P wave, or if you see P waves, then you know that this arrhythmia is happening above the ventricles. It's a supraventricular arrhythmia if P waves are present. The next question is are the P waves identical? So is the same foci that is driving this arrhythmia, is it the same, or do you have multiple foci triggering this arrhythmia to be present? So is it over here, you get one, and then you get another one over here, and now you have one over here, and another one over here, that's kind of driving this, and they're competing against each other to take control of that rhythm. And you can see that in situations like multifocal atrial tachycardia, which we'll talk about in our next lecture. If the P waves are not identical, there are two possible causes. So it could be additional pacemaker cell firing, like we said, or there's another component of complex superimposed on the P wave. So this would be like you have the T wave occurring, but then the P wave is occurring earlier than normal, and now that P wave is superimposed onto that T wave, which is going to give you a distorted looking wave. Then the next question is the rhythm regular or irregular? And then does each QRS complex have a P wave? So do you have a P wave followed by a QRS? Or is P waves and QRSs not coordinating, not talking to each other, and now you have more P's than Q's, which would lead to a different type of an arrhythmia. And then the last question is the PR interval constant? Is that conduction between the SA node to the AV node and that pause in the AV node, is that constant, or is it changing from beat to beat to beat? Okay. So let's start looking at some examples of these arrhythmias and talk about what makes this arrhythmia unique, as far as also what is going on that's causing this arrhythmia to occur in the first place. And we're going to talk about the remainder of our lecture is the bradyarrhythmias that we may encounter and which the PANCE blueprint requires you to know. So the first one is, of course, sinus bradycardia, probably the most common most common bradyarrhythmia that you're going to encounter. Most of you sitting in your seats right now have sinus bradycardia because your resting heart rate is less than 60. That is, of course, unless you've had 10 cups of coffee like me. So, but to be at the AV node to just before the split of the bundles, this is called a junctional escape rhythm. It's going to have a rate of 40 to 60 beats per minute. There's not going to be any P waves necessarily there because it's not an atrial-driven rhythm. There may be some inverted P waves after the fact, but this is going to be because you have retrograde propagation of that signal through the AV node and up through the atria towards the SA node. So you may have retrograde and delayed P waves present, but those are not driving the rhythm that we encounter. It's just retrograde propagation. But the key thing that kind of differentiates this junctional escape rhythm versus a ventricular escape rhythm is the QRS is going to be narrow. Because that propagation of that action potential that was not generated at the SA node is still going to use the left and right bundles normally. So you're still going to get that coordinated ventricular depolarization occurring, leading to that normal narrow QRS. But let's say now that this rhythm is being generated from after the branch of the right and the left bundle, even down to the Purkinje system, or sorry, the Purkinje system. This is a ventricular escape rhythm because now you're not using those right and left bundle branches properly. So if I were to have an action potential generated, say like right here on the right bundle, what's going to happen is, yes, I'm going to propagate the action potential down this way and I'm going to get the right ventricle squeezing. But to get over to the left side, either I propagate up and then back down the left, or I go myocyte to myocyte until I get over to the left. And maybe I'm going to encounter the conduction pathway, and maybe I'm going to get that coordinated response. But it's going to delay that ventricular depolarization because the right's going to, in this example, the right's going to occur first, and then the left is going to occur. So it delays that depolarization, so it's going to widen your QRS. So if you see a wide QRS, be thinking of a ventricular escape rhythm in this setting. And here's some examples of that on an EKG. So this is a junctional escape rhythm, and this is a ventricular escape rhythm. So we said you're not going to have any P waves. If you do, they're inverse and delayed. I don't really see anything there on this rhythm. But what I do see is a narrow complex QRS. So I know that this is at least happening above the bundles, but not in the atria because there's no P waves. Now look at B, which is a ventricular escape rhythm. Now I've got a widened QRS complex because you can see, let's say this is the left bundle depolarizing first and then the right bundle depolarizes. It kind of gives you that bunny ears kind of appearance, right? But you can see that widened QRS present. I don't see a P wave. And that's the thing that's going to kind of separate this from a right or left bundle branch block because there's no P waves. Okay, let's move on now and talk about the different heart blocks. So first degree AV block basically what's happening in this is it could be a number of different factors. Most common one being you have like this parasympathetic overdrive that's really slowing down the conduction. So it slows down that propagation of the action potential through the AV node and down through the His-Purkinje system. So and that will then lead to the kind of that delayed ventricular response, or that ventricular depolarization when you encounter this. And so when you talk about the criteria for a first-degree AV block, you've got to have that prolonged PR interval, but it is consistent. So this PR interval for this beat is the same as the PR interval to this beat, which is the same as the PR interval to this beat. So you've got to have that consistency. You also have to have a P for every Q and a Q for every P. So you're not going to have any dropped beats at all with this. And because you are using the conduction system normally, you're going to have that narrowed QRS. So that's going to be your criteria for a first-degree AV block. Now, is this pattern predictable or not? It's predictable, right? It's consistent. It's just everything is prolonged. Do we like predictability in medicine, or do we hate it? We like it, right? So, because we do have that predictability in this arrhythmia, most of the time, this is a completely benign, asymptomatic condition. Are we putting pacemakers in 6-year-olds who have first-degree AV block, who are completely asymptomatic? The answer is no, because it just happens to be something that they deal with, or can deal with. They may outgrow it as they get older, but we're not jumping to put pacemakers in folks who are asymptomatic with this benign condition. Now, there are some situations where it is not benign, but these folks tend to also be symptomatic from it as well. Or it's like your elderly patients who have so many other comorbidities that they're at risk for their heart failing at any moment. So, but for the most part, first-degree AV block is a benign condition that tends to be asymptomatic. When we talk about second-degree AV block, recall that there's two types of second-degree AV block. There's Mobitz 1 and there's Mobitz 2. Mobitz 1 being your winky Bach, and the saying longer, longer, longer drop, then you have a winky Bach, can help you kind of differentiate that from like a Mobitz 2. This is typically a benign condition. You may see it in children, you may see it in high-performing athletes who are in good physical shape. They also tend to be asymptomatic from this condition. But what you're going to see in your patients with this is that PR interval is going to be one thing, and then the next beat, that PR interval is going to be a little longer. Then you're going to get a drop. It gets longer, and then you get the drop. Here's your drop beat. Then it resets, and now that PR interval goes back to maybe even normal looking, and then the next beat is a little longer, and then it gets longer, and then eventually it's going to drop a beat again. So a winky Bach, longer, longer, longer drop, then you've got a winky Bach. Now compare this to a Mobitz type 2, where now you have a P wave that's present and upright, and you have a normal PR interval. So it looks like this is a normal sinus rhythm. However, all of a sudden, you get a drop beat. It's random. We have no idea it's going to happen. It's just all of a sudden there's a drop beat. Is this predictable? The answer is no. So again, do we like things predictable in medicine? Yeah. So if it's not predictable, then this is something that we should be concerned about. So if you have somebody with a Mobitz 2, be concerned about, and they need to get referred immediately to cardiology, if not go to the emergency room. Because what can cause this is if they have like an extensive MI that's affecting the interventricular septum, it can lead to this. But the concern is that this can go on and develop into third-degree AV block. and now you have no coordination between the atria and the ventricle. And the treatment for this is going to be a pacemaker. Because we got to get that predictability back. So if I can't trust the body to do that predictable behavior, I'm going to need to do something to give me that predictability again. And that's where the pacemaker comes in. Now compare that to the third degree AV block where there is no communication between the atria and the ventricle. They're doing their own things. So that P wave is going to occur anywhere in the cardiac cycle. So this P wave, you look at the PR interval here, you're like, okay, that's long. And then you're like, okay, this looks long, but this T wave looks a little weird, and you kind of see it's like instead of it being kind of a slow swooping motion up, it's kind of abrupt and then kind of slowly drags on. And that's because there's a P wave occurring inside of that T wave. But it's not necessarily being propagated. It's not triggering a QRS kind of response. But you can see then, when I look at this PR interval, that's different from this one. It looked like it was maybe really long to maybe getting shorter. It's kind of like the opposite of a winky buck, right? And then it looks like, okay, here's a drop beat. Now there is no PR interval really, it just immediately goes into the QRS. So you can see that there is no predictability at all in a third degree AV block. And these folks, because there's no coordination of effort or anything like that, they tend to be symptomatic from this. And the treatment is to get that predictability back, get that coordination back by putting in a pacemaker to provide that coordination of the atria and the ventricle again. Here's just another example of a third degree AV block. All the P waves are labeled, and then the QRSs are as well. And you can just see so many of the P waves are not triggering a ventricular response. Let's look at an example, and this one I'll give you as a hard example, but look at this EKG and tell me what you think is going on as far as which block we're seeing on this. What are your thoughts? Am I hearing delta? Is that what I'm hearing? Lobits 2? Okay, I agree with that. And you may be wondering, well, yeah, I have drop beats, but it looks consistent, right? Well, let's walk through and kind of see what's going on. So, is this a first degree AV block? No, because you have drop beats, right? So it can't be a first degree AV block. Can it be a Mobitz 1? Longer drop. Now you got a winky back. So let's look at this interval. Is this longer? And the answer is no. So I'm not getting that prolongation of the PR interval before I get a drop beat. So it can't be that. Is this complete heart block? Well, looking at it, it looks like when there is a QRS response, that PR interval is consistent from beat to QRS to QRS. Would you agree with that? And remember, we said complete heart block, there is no communication, so there's no consistency at all. And so the fact that I do have that consistency in my PR interval when I do have a P wave followed by a QRS, it can't be complete heart block, which leads us to a Mobitz 2. But this is just a 3-to-1 conduction, so you have to have 3 P waves for every 1 actual conduction QRS. So kind of think of it as you have 2 drop beats followed by an actual beat. So, I would read this as a Mobitz 2 heart block EKG. I promise you I will not give you EKGs this difficult on the exam. Okay, so let's move on and let's talk about the next breed arrhythmia that the PANTS blueprint would like you to know, and that is sick sinus syndrome. There's a number of different arrhythmias that kind of fall under this umbrella, but the most common one is a tachybrady syndrome. Think of it as the heart goes through a pause. It then determines I need to speed up the heart rate in order to get a cardiac output to meet the demand. So it's going to beat super fast, but it can't sustain having that fast rate for very long. So then it kind of goes through a long pause to kind of rest and recuperate for this. So you're going to get that section of tachycardia followed by a prolonged pause or even a severe bradyarrhythmia before you get a tachyrhythm again. And things that can cause this are just being elderly, things, having all these other comorbidities that affect the heart. It's maybe damaging the SA node itself. Maybe for some reason you have this severe, like increased parasympathetic overdrive for some reason. Maybe these patients are on too high a dose of their beta blockers or calcium channel blockers that's causing that rate to drop too far before the heart rate kind of picks up. Okay, I need to beat a little faster, and then it then leads to that pause and bradyarrhythmia again. And you can imagine if this is not medication induced, so I don't have a reversible cause, this is not a great rhythm for a patient to be experiencing. Because this is going to be your patient just walking normally and all of a sudden collapsing because they go into this long pause, and now the central nervous system is not getting the blood, the oxygen that it needs, and it's going to trigger that syncopal episode. So that's not great for patients to have. So the way you treat it is, let's keep that rhythm working normally by putting in a pacemaker. And there's a couple of different versions of pacemakers that you can do. You can do a single chamber, which is just a single lead that goes into a designated area of the heart. Let's say we're going to put it in the atria, so now that the SA node is no longer required to generate that cardiac rhythm. Now I've got the pacer that's going to do it, and it's going to do it in the AV node. But to use a single chamber pacemaker, you've got to have a normal conduction pathway distal to it, right? What happens if the AV node is also damaged? If I put it in the atria, and I get that atrial kick, I stimulate that atrial kick, but then it's stuck in the atria, am I really doing that patient any good? The answer is no, right? So because of patients exist like that, we then also have a dual chamber, which is now you have at least two leads where you put one in the atria and you put one in the ventricle. And they will coordinate the stimulation of those two chambers. So you're going to have the atria stimulated first, you're going to get that atrial kick during diastole, you're going to get that flow of blood from the atria into the ventricle, so you have an adequate preload. Then the ventricular lead is going to then stimulate the ventricle to squeeze, and then it's going to stimulate systole to start, and you get that circulation of blood. Now you can also put, you can put both those leads in the ventricles if you need to. You can put them both in the atria if you need to. So there's different versions of this, but ultimately you're trying, with the dual lead, you're trying to restore a normal physiologic coordination of the atrias and the ventricles working together for the cardiac cycle. And on your EKG, you're going to see these little pacer spikes, and you're going to see it stimulate that. So in this example, that single lead that we have is in the ventricle, and when it triggers, it's going to trigger a ventricular response. You get a QRS complex related to it. So this is a single chamber ventricular rhythm. Here's a dual chamber, which is in the atria and the ventricle. And you can see you get a pacer spike, you get your P wave, then you get another pacer spike, which then stimulates the QRS complex to occur. So it's kind of restoring a normal physiologic cardiac cycle. Okay. Let's go ahead and take 10 minutes We'll come back. You might see with those pacer spikes. Here's another example of it. But this is a biventricular pacing. So this is now those two leads are actually in the left and the right ventricle. Coordinate those two ventricle squeezing. So this would be in a situation of, say, like the bundled branches are not functioning properly. So even if I were to put a lead in the right ventricle, there would be a delay in response to the left ventricle. So to kind of get rid of that delay, let me put a lead in both ventricles to coordinate that squeeze and that response. So just an example of a biventricular pacing. Yeah?
Why do those spikes go up instead of down?
Kind of depends on just the placement of the leads, where they are in relation to that electrode. So yeah, because what's happening is that action potential is going towards the lead, so it's going to be that upward deflection. In the other examples, it was going away from the lead, so it's giving you downward deflection. Yeah, so it's just really placement. Okay. So let's talk about our bundle branch block. So we've got, of course, the left bundle and we've got the right bundle. But what happens is, in a bundle branch block, one of the bundles, whether it be from like ischemia or an infarct of the interventricular septum, causes that wire basically to get cut. So that will not conduct an action potential through that section. This can also be caused from chronic things like remodeling. So we talked about the adverse cardiac remodeling that occurs in like heart failure and stuff like that, and why we see mortality benefits with beta blockers, ACEs and ARBs, MRAs, because it limits the cardiac adverse remodeling. So we may save the conduction pathways by having them on those medications, so you don't develop another condition on top of what they already are experiencing. But when we get that conduction block occur in the right bundle, what happens is the conduction of that action potential terminates coming down the right bundle. It will go down the left bundle normally, and then it has to rely on myocyte to myocyte communication over to the right. So the depolarization of the right ventricle requires that communication from the left. And that's going to, of course, delay that coordinated squeeze of the left and right. So what's going to happen is you're going to see that left ventricle squeeze first, that depolarizing first, then you're going to see the right depolarize. Because the myocyte to myocyte communication and propagation of that action potential is slower than if I were to use the normal conduction pathway. And so the criteria for a right bundle branch block is you have to have a YQRS. Typically we see an RSR prime pattern in V1 through V3, so this is called like our bunny ears, right? So you can see R, S, R prime, kind of our bunny ears appearance in V1 through V3. But you also have this slurred S wave in the lateral leads. And you can kind of see, instead of this being kind of abrupt S up, you can see it's kind of slow as it goes up to its baseline. So that's that wide slurred S wave in your lateral leads. When we look at the left bundle branch blocks, now we're just thinking about the opposite occurring. So now that signal going down the left is blocked, and now it's reliant on the right side to depolarize the left. And things that can cause this are things that cause stress of the left ventricle. So aortic stenosis, remember that pressure overload that the ventricle experiences with aortic stenosis, especially as it progresses and gets worse. Ischemic heart disease, hypertension, so we gave left ventricular hypertrophy, right? Dilated cardiomyopathy, I'm dilating the ventricles, so now that's going to stretch that conduction pathway and stretch the left bundle branch. An anterior MI that knocks out the left bundle, hyperkalemia, and even digoxin toxicity can cause a left bundle branch block. The criteria for a left bundle branch block is still, because you're not using the normal conduction pathway, you're going to have that widened QRS. You're going to have what's called a dominant S wave in V1. This is also known as a W. And a broad monophasic R wave in the lateral leads, or an M. So it almost looks like bunny ears in your lateral leads. And what you're going to see is, to kind of help you remember which goes where, is the mnemonic William Marrow, where I get a W wave in V1 in the left bundle branch block with an M in the V6. And now with the right bundle branch block, it's the opposite, where I have that M wave in V1, the bunny ears, in right bundle branch block with a W wave in V6. So just an easy way to help you remember what to expect with a right bundle branch block and what to expect with a left bundle branch block. And remember, both of them are going to have that widened QRS complex. But why are we concerned about left bundle branch blocks? And the concern is that, one, a new onset left bundle branch block could be the equivalent of a STEMI. So a new left bundle branch block, work it up like it's a STEMI, because that could be the indicating sign of it. And the reason for that is folks who have left bundle branch block STEMIs tend to not have chest pain. So it's a silent MI. So they're not coming in with chest pain. You just happen to notice on an EKG, for whatever reason, they have a left bundle branch block. You could save their life. Because even though they're not presenting with that chest pain, the same process that's leading to cell death is occurring in that patient. But does it make sense that left bundle branch block is an abnormal depolarization, right? We're getting a distortion of the normal ventricular depolarization, right? So does it make sense that if I have an abnormal depolarization, I'm probably also going to have an abnormal repolarization event? I'm not going to go from abnormal to normal, right? So this then leads to a lot of other additional distortions of your EKG that are just really because of the left bundle branch block, not that there's another process going on. But if that left bundle branch block is hiding a STEMI, we're in a predicament here of how do I know when to work somebody up and when not to. And this was a challenge that a lot of cardiologists had to deal with. And Dr. Scarbosa she was a cardiologist who kind of came up with this criteria, or a set of criteria to help you with the diagnosis of a MI in somebody with a left bundle branch block, because you're not going to see the normal STEMIs, the ST elevations, in somebody who's having an abnormal depolarizing event in the first place. So what she said is, if you have a patient with left bundle branch block, if you have at least one lead with at least a 1 millimeter of concordant ST elevation, then that is a STEMI. So what does that look like? So if my QRS abnormal depolarization is in the upward direction, if I have that 1 millimeter elevation of my T wave in the same direction, so I have concordance, then that is a STEMI. Concordance is bad in a abnormal depolarizing setting. If patient doesn't meet criteria 1, let's then go down to criteria 2, which is you have at least one lead in V1 through V3 with at least a 1 millimeter of concordant ST depression. Again, concordance equals badness, right? So what does that look like? So if my QRS is in the downward direction and I have that ST depression, so down, down, then that is bad. And that should be treated like it's a STEMI. If they don't meet that criteria, then the third criteria is this excessive discordance. So we say discordance is good, but is excessive discordance good? And the answer is no. And what that is if you have at least a 1 millimeter ST anywhere where it's 25% of the depth of the preceding S wave, then that's bad. So unfortunately, in this case, you're going to have to count these little boxes from baseline and then check. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, let's say 14 millimeters down. Then let's say 1, 2, 3, 4, 5, 6, 7 up. So 14 down, 7 up. Is that greater than 25%? The answer is yes, it's 50%, right? So that is a excessive elevation of a discordant ST elevation. So if you meet any one of these criteria in a left bundle branch block, it is a STEMI until proven otherwise. And this is just kind of that flow chart on how you can arrive at that diagnosis of a STEMI using Scarbosa's criteria. So a couple of examples of this. So this is a left bundle branch block. But here's a left bundle branch block. And if you notice, look at those ST depressions. A concordant ST depression. So that meets the criteria of criteria 2. So this would be a STEMI in a left bundle branch block setting. Okay. Moving on in the different bradyarrhythmias, let's now look at sinus arrhythmia. This is something you're going to see regularly on your computer reads of your EKGs, but you may also see this because you may be thinking that this could be like a tachybrady or a sick sinus syndrome, but really this is a normal thing related to breathing. And so if you ever encounter a situation where you suspect a sinus arrhythmia, have them hold their breath while you're doing that 10-second EKG and see what happens to that rhythm. Because basically what's happening is, as you take a deep breath in, you're going to decrease your vagal tone, and that's going to cause the heart rate to increase. Because what else is happening with inspiration? You're drawing in more blood, you're getting an increase in your venous return, right? So if I'm having an increased preload, I need to deal with that extra preload, and one of the ways I do that is increasing my heart rate. So I'm getting rid of more volume per minute than normal. When I exhale, on the other hand, I get an increase in vagal tone, which then means I'm going to have a decreased heart rate. So what ends up happening is, when you're looking at your EKG, okay, you're going to be like, okay, my rate is 60. But then it slows down even more. So now maybe in the 50s, 40s, and then it slowly starts to speed back up, and then it gets normal, and then it starts to slow down again. So people may interpret this as like a sick sinus syndrome or like a pending cardiac arrest or whatever, but really it's just the patient is breathing while they're doing the EKGs. Here's just another example of a sinus arrhythmia on a full 12 lead. You can see the rate here is what? 300, 150, 100. So about like 70, 80 something, right? But then got what? 300, 150, 100, 75. Now I'm looking at maybe more closer to like 65. And then I've got 300, 150, 100, 75, 60. And then it then starts to speed back up again over here. So you can just see kind of that pattern of it slows down and then it speeds up. And then it slows down and then it speeds up. So. a normal benign condition that's caused by breathing. Now let's look at another rhythm that the PANS blueprint requires you to know, and that's an idioventricular rhythm, which it may look like V-tach, but instead of having a fast heart rate like you normally get with V-tach, it actually is slow, to the point where it could be less than 50 beats per minute. So it may look like V-tach, but it's just going excessively slow. Or you can have this other kind of next thing, an accelerated idioventricular rhythm, which is 50 to 110 beats per minute. So it's faster, maybe a normal physiologic rate. But remember, a V-tach is going to be in excess of 150 beats per minute. So that 110 is still slower than what you would expect of a V-tach. And what can cause this is things like digoxin toxicity. It could be an ischemia or an infarct. But that accelerated idioventricular rhythm is something that we normally see on our EKGs after somebody goes into cardiac arrest, and then we get a return of spontaneous circulation. So we get their heart beating again. You may notice that they go into this rhythm, and it's not concerning in that setting because it's just a byproduct of that perfusion being restored to those myocytes. And this is an example of that. So this is slow, but it's not normal looking. Here's your normal beats, right? Do those look the same? And the answer is no. You may even think of those as being like premature ventricular contractions, but this is a idioventricular rhythm. Speaking of premature contractions, you can have premature atrial contractions, you can have premature ventricular contractions. And really what's the difference is where is that foci that's causing that premature contraction occurring from? Is it from the atria or is it from the ventricle that's causing this? And with PACs, it's this premature beat arising from an ectopic focus. So this is not coming from the SA node necessarily. This is coming from something other than the SA node. And typical causes of this would be things like anxiety attacks, excessive caffeine, low electrolytes. And normally, these don't really cause any problems. If you see PACs on an EKG and somebody is asymptomatic, doesn't necessarily require you to do a workup on it. The one situation where there is a concern with a patient having this PAC is in settings where maybe they have Wolff-Parkinson-White. And we'll talk about Wolff-Parkinson-White in our next lecture, but that controlled Wolff-Parkinson-White beating at 60, 70 beats per minute all of a sudden gets hit with that PAC, and now it triggers a tachyrhythm. Now there's a problem with this. Here's an example of a premature atrial contraction. So you have, so here's your what should be your T wave, but then you get that premature atrial contraction that triggers that QRS because you do already have some of that area depolarized, or sorry, repolarized with the T wave there, right? It triggers that contraction, but then it kind of resets, and then you get a different looking P wave that then is followed by QRS. But then you get another premature contraction right here. And you can see just kind of how it changes the rate when you have these premature contractions. Premature ventricular contractions, so now this foci that's triggering that action potential is occurring in the ventricle and not in the atria. And when it occurs in the ventricle, you're not using the conduction system normally, so it's going to trigger a Y complex QRS. And you'll see this frequently, kind of in the same settings that you see premature atrial contractions. And again, these are not very concerning unless you have like an excessive amount of these. But in settings where you have additional cardiac disease like Wolff Parkinson White, it can trigger an arrhythmia or an accelerated rate to develop with this. So you've got to be careful if they're with premature ventricular contractions in patients who have other cardiac diseases present. Causes of it, so we said the same thing as premature atrial contractions, so anxiety, excessive caffeine, low electrolytes, so they can all cause that. And here's an example of an EKG showing premature ventricular contractions. So this looks like a normal cycle, right? Normal P wave, QRS, T wave. But look at this one. Is that QRS complex the same as this widthwise? The answer, of course, is no, right? That's a widened QRS. Then you see a normal looking one that looks the same as this one, right? But then you get a premature ventricular contraction. There's no P waves before it. And so this looks like this one. And then you can see, and then this one looks different than this one. So that tells you it's just a different foci that's triggering that premature ventricular contraction. And then, of course, the last bradyarrhythmia that we are required to talk about is the ultimate bradyarrhythmia, which is no rhythm, no heartbeat, asystole. Okay. Of course, lots of causes for this. This is not sustainable for life because you're getting no circulation unless you have other things there to circulate the blood for you, like cardiopulmonary bypass or whatever. But this, of course, is a bad rhythm. This, of course, is the favorite rhythm for Hollywood to shock. And we'll learn why that's not a good thing to do on our last ALS lecture, why you don't shock a asystole rhythm. But you do need to get the blood circulating, so you've got to be doing CPR. And then, of course, you need to be trying to give them medicines that we'll talk about to try to restart that heart, to restart the action potential generation of your pacemaker cells and stuff. So, but we'll talk about that more on our ALS lecture and how to treat and manage this. But obviously, be able to identify asystole. There's no P waves, there's no QRSs, there's no T waves at all with that. So, questions about bradyarrhythmias? All right, have a great Thanksgiving. Enjoy.